Okay, good evening everyone, and welcome to the first case conference webinar for the fall of 2018 for the Clinical Immunology Society. My name's Andy Snow. I'm at Uniformed Services University, and I'll be one of your moderators tonight. I'm joined by Nick Hartog, who's an assistant professor at Michigan State University, and will moderate our second case. I'll remind you that the webinar series is organized by the Early Career Immunologist Committee of the CIS. So if you're interested in helping us put those together, please consider joining that committee. And we're always looking for new and interesting cases. So if you like what you see tonight or at other webinars, please consider presenting a case down the road. So we've got two terrific cases tonight. The first will be presented by Dr. Christin Deal, who is an allergy and immunology fellow at the Geffen School of Medicine at UCLA. And we're joined by our senior mentor for this case, Dr. Manish Butte, who's the Division Chief of Allergy and Immunology at UCLA. So with that, I will turn it over to Dr. Deal.
All right, good afternoon, everybody from the West Coast. Thank you guys for giving us the opportunity to present this interesting case. The title of our presentation is SCID, that isn't SCID, or is it? And as we get into the case a little bit more, hopefully you'll begin to understand why we chose that title. So I'm going to jump right into the presentation so we don't waste any time. So a 22-year-old male presents to Allergy and Immunology Clinic with severe cachexia, diffuse rash, abdominal pain with diarrhea, leg edema, recurrent fevers ranging from 101 to 103, and multiple recent hospitalizations for diarrhea and infection. His past medical history: he was born at term. He was a C-section with no complications, and he was born in Arizona in the 1990s. And around 4 to 6 weeks of age, he developed a rash and otherwise had a normal infancy. This slide is a little intentionally vague, so I'm going to leave a little bit up to your imagination for right now. And we'll fill in some of the details later. His family and social history: as family history is significant for thyroid disease in the father, but there's no consanguinity, no immunodeficiency in the family, and the patient does have two siblings that are half siblings from the mother. One boy, one girl, and both of them are healthy and alive and well. And for social history, he lives with his father in Arizona. On physical exam, we have several pictures, but he is tachycardic in clinic. On general exam, he's a cachectic male. For head and neck exam, he's had the distal portion of his nose removed. He has multiple squamous cell carcinomas. He has gingivitis and poor dentition, but he has no thrush. On his abdominal exam, it's soft and non-tender, but mildly distended, and he has some prior surgical scars present. On his extremities, he has pitting edema up to his mid-tibia. He has significant edema of both knees bilaterally, you can see in the photo. And on his skin, he has flat and tan verrucous papules on his chest, abdomen, and back, some forming plaques, and he has hyperpigmented brown sclerotic plaques on his arms and legs, some with atrophy. Of note, he has no palpable lymph nodes on exam. So we have some initial labs, and he was seen at UCLA on at least 2 prior occasions. So I went ahead and included the labs from the times that he was seen here, one when he was 2 years old and one when he was 18 years old. So to sort of summarize his labs so far, when he was 2 years old, he has decreased T cells with an inverted CD4 to CD8 ratio, but normal B cells, low NK cells, and normal immunoglobulins. When he represented at 18 years of age, he continues to have low T cells with an inverted ratio, normal B cells, although now it's low normal, low NK cells, and low immunoglobulins. And then when you're seeing him today in office when he's 22 years old, he has even lower T cells, no B cells, low NK cells, and low immunoglobulins with the exception of IgG, but he's on replacement immunoglobulin. So sort of in summary, this is an adult male with clinical and laboratory evidence of a combined immunodeficiency. He has evidence of lymphopenia, and of note, I didn't include it in the slide, but his T cells are all mature phenotype. He has hypogammaglobulinemia and is on immunoglobulin replacement, and recently has been having more infections, has had severe enteropathy with electrolyte abnormalities requiring multiple hospitalization. He has diffuse warts, diffuse rash. So I'm going to pause for a second and see if anybody has any follow-up questions about this initial presentation, if anybody has any ideas of a differential diagnosis or what they think might be going on.
Thanks so much, Kristen. I'll just remind folks that might be new to the webinar, or for those returning, that if you'd like to submit a question, go to the attendee chat box on the left side of the screen and you can type questions in there. So do we have any early thoughts on this case with regard to a potential differential or what might be going on? So we have one question from Joyce Yu about vaccines. What does its titers look like?
So he was on immunoglobulin when he presented at 22 years of age, and so we didn't have any reliable vaccine titers at that time.
Got it.
Yeah, and he didn't get any. He didn't get a typical vaccine course because the parents were sort of all natural in their approach to his illness and whatnot.
That's a euphemism.
Yeah, right.
Other questions or thoughts at this point in time? All right. Oh, when in Arizona did he have any exposures? Endemic to the area. Coxie, yeah. I don't know. The question was, when in Arizona did he have any exposures endemic to the area? And as far as we know, he didn't have any significant exposures or any endemic diseases. He did have sort of did get norovirus exposure, but nothing significantly unique to Arizona.
Were any proliferation studies done on his health?
Yeah, so remember we did cytokine.
Did it respond?
Yeah, so we did a proliferation study using anti-CD3 and CD28, or anti-CD3 plus cytokines. This was done by Medical College of Wisconsin using CFSC, because he was still lymphopenic. We thought that would be an appropriate way of measuring proliferation. And what we saw was a very minimal but not zero proliferation after a week of stimulation. There was not much of an increase, not much proliferation with CD3 alone. And with IL-2, there wasn't much proliferation add-on. But with IL-7 and IL-15, in addition to anti-CD3, there was a decent amount of proliferation. And similarly, with CD3 and CD28, there was a decent amount of proliferation.
Okay.
Not zero.
All right. So
right. Well, yeah. Why don't we move on for now?
Right.
Then we can. Yeah.
So sort of to fill in some of the gaps. So around 1 to 2 years of age, he developed some rash. He had a little bit of thrush, some diarrhea, and failure to thrive. He was given a presumptive diagnosis of a combined immunodeficiency at that time. The family declined bone marrow transplant, and they were lost to follow-up. So from ages 2 to 13, the father gave the patient alternative treatments, and his GI and skin issues resolved, and he was generally healthy until he was around 13 years of age. And the dad has brought us pictures to show this sort of young, healthy looking child. And it wasn't until he was around 18 years old when he presented back to UCLA, because he had had an ongoing rash for 5 years and wanted a derm evaluation. So on his derm evaluation, they noted cutaneous granulomas, verrucous lesions, and squamous cell carcinomas. Genetic testing was performed while he was back within our system during that time. But unfortunately, after that, he was lost to follow-up again and had significant deterioration, recurrent hospitalizations, and was receiving immunoglobulin replacement during that time. And then when he presented back at 22 years of age, he was having chronic diarrhea, huge electrolyte abnormalities, recurrent hospitalizations, recurrent fevers. He had hepatitis, and this had all been going on for about a year, where he was in and out of the hospital with sinopulmonary infections, recurrent skin infections. He was having weight loss, and was not feeling well. So a little bit more detail about the diagnosis and the genetic testing that was done when he was 18. And we did a whole exome sequencing, mostly because nobody was expecting that we would have a mutation in the common gamma chain in an 18-year-old male. But it showed that he had a mutation in the IL-2RG, resulting in a missense mutation that was inherited from his mother. The mutation was known pathogenic, previously identified, and was presumptively the explanation of his combined immunodeficiency. The problem that, the struggle that we had with this was why did he have lymphocytes? Why were his T cells high? How is he still alive? And then again, sort of where did his B cells go? They were present in 2013, and then in 2017, when we repeated them, they were no longer there. So our initial thought was perhaps that this was evidence of maternal engraftment, and he was living off of his mother's T cells up until this point. And so we did some evaluation to see if he had evidence of maternal engraftment. So we did biopsies of his skin lesions, we did a biopsy of his colon, and we looked at knee aspirate. There's no evidence of graft versus host disease. And additionally, we did short tandem repeats from the buccal swab versus his sorted T cells. And the short tandem repeats were identical, arguing against maternal engraftment, showing that the T cells were his own T cells. So the next step was we looked to see if his T cells expressed the common gamma chain. And so we did FACS evaluation of CD132 and CD127. CD127 is on the left and CD132 is on the right. And the patient is in red and green, and then the blue is the control. So the FACS showed that he had normal CD132 expression on all of his T cells. So at this point in time, we know that he's making his own T cells and that they're at least expressing CD132. We also had them evaluate NK and B cells. Unfortunately, because he was lacking B cells, the results for B cells were unreportable, but he did have normal CD127 expression on his NK cells. So in order to evaluate whether or not the common gamma chain was functional, we had NIH evaluate functional studies. So we had the patient as in the pink and then the control is in the purplish color to see if his common gamma chain would signal and produce phospho-STAT5 in response to IL-27 and 15. And he does make phospho-STAT5 signaling to all three stimuli. It was reported to be normal. So at this point in time, we know he has his own T cells, they express the common gamma chain, and it does work functionally. So our questions at this point were, is the mutation clinically significant? And because if he's making his own T cells with normal CD132 expression, normal phospho-STAT5 signaling in response to IL-27 and 15, is the mutation incorrect? Did we miss something? And still the question is, what happened to his B cells? So if anybody has any thoughts, I see someone. Mm-hmm.
Yeah, can I make this is Gigi. Can I make a comment about these statements? I think that if you go back to the CD132 expression, it was slightly reduced. I wouldn't say it was normal. Right. The red curve as compared to the blue curve is actually shifted on the left. So it does express a mutant form of gamma chain, but I would say at suboptimal level. And along with that, the assay that Sergio ran at here at the NIH, that assay uses optimal concentrations, so it's an overstimulation with IL-2, IL-7, IL-15. What we don't have in this case, and we've seen similar cases in other patients, is what happens if you use lower amounts of those cytokines. Because some of these patients with missense mutations in a common gamma chain gene respond poorly to lower amounts and perhaps more physiological amounts of cytokines as opposed to high amounts as done here. So that's one comment about the gamma chain expression and function. I should say one thing about the B cells. This is very interesting, and honestly, before coming here, I had never seen anything like this. We now have 8 patients with common gamma chain that either lost their graft, and so they were supposed to remain with their autologous B cells. These had received unconditioned transplant, or had similar situation as this patient with a missense mutation in common gamma chain, and in adulthood, they all lose the B cells. 8 patients. So this is not unique. We don't know the mechanism. I wonder, I don't remember, Manish, you may remember, did we look at the marrow in this specific case? Do you know if we looked at his marrow? Because the other patients had CD8 infiltrates in the marrow. Is that what you saw?
We did.
What we saw?
His granulomatous, you guys saw. We have a little bit of we have a slide addressing the B cell gen a little bit later too. The question from Ben Wright was about monocytes were in the 400 range from all the way back from what we could measure. So normal.
Yeah.
Greg,
Christin, can I ask a quick question?
Sure.
Christin, can I ask a quick question? I don't know how relevant this is, but when you went through the timeline, you mentioned the from ages 2 to 13, Dad gave some kind of alternative treatments, and he seemed pretty healthy through that period. Do you have any idea what those were, or why?
Yeah, there were a lot of
was seemingly healthy then.
And colloidal minerals is what he says. Colloidal zinc, but nothing crazy like arsenic or mercury or anything.
Mm-hmm.
Okay.
IL-2.
IL-2. Okay.
Retroviral. No retroviral vectors either.
All right. So
Gigi's points, just to be clear, he's raising this point that the CD132 expression is about half of normal on that FACS plot, and the function may be hypomorphic. We're stimulating with a lot of signal. Those hypotheses go towards the idea that this variant is hypomorphic and that he has some sort of leaky skin. And that, I think, is sort of a really important point. The other possibility that we addressed was whether this is a reversion mutation. We'll talk about that in a second, which Greg mentions in the chat box over here. And the third is whether it's maternal engraftment. We were able to rule out maternal engraftment by genetic. So to address the idea of better understanding the genetics, we'll go on.
Yeah. So in order to ensure that we did adequate genetic studies on him, we had them reanalyze the 2013 whole exome sequencing, which was performed on whole blood, and 41 out of 44 reads were mutant, and 3 of 44 reads were wild type. And then in 2017, we had them do whole exome sequencing on his sorted T cells, which showed 112 and 112 out of 112 reads. So 100% were wild type. He had no mutant mutations on his T cells. So therefore, we presume that he had a reversion mutation, allowing him to produce his own T cells. In order to further evaluate the clinical significance of the IL-2RG mutation, we did exon activation studies on Mom, and her T cells were skewed. 97% is the result that we got back. So this indicates that the mutation is clinically significant.
Yeah, so I think Kristen's jumping a little fast here, but the what we're trying to say here is we're faced with an interesting conundrum still to address the question that Gigi raised, which is the V152A variant actually biologically relevant. It's hard to assess because there aren't any B cells to grab onto and hold onto and study. There aren't any NK cells to grab onto and hold onto and study. And the T cells all have wild type reads. So their protein that they're producing, the common gamma receptor and all the cytokine receptor signaling that we could assess in the T cells would be normal. And so how do we assess whether this V152A variant actually has any biological relevance? It turns out in the patient, we couldn't think of any answer. All his cells, as far as we could grab onto them and measure them, that care about common gamma and that express common gamma aren't accessible. And so we went to the mom, knowing that she was a carrier of this variant, and asked whether we could show it had a biological relevance in her. And the way we addressed that is by then looking at her sorted T cells and asking if they were skewed in one direction or another. If they were, then that means that the variant on the X chromosome is biologically relevant enough to skew the development of the T cells, and that's what we saw. So I hope that makes sense to the audience here.
Mm-hmm.
Anthony wrote something
yes,
here. Do you want to address
absolutely. So Manish, did you have a chance also to look at? Did you have a chance to look at repertoire especially by gamma rearrangement, to find out where does the reversion occur in T cell development? Is it happening in clips or which cells actually?
We gave IL-7 to bone marrow and looked for phospho-STAT5 there, and did that by CyTOF, so we could look at every cell type as we could responding to IL-7, hoping that we could track down where the signal arose, where it came up, and therefore those cells would have the reversion. That was the strategy we ended up picking. Does that make sense as a strategy, or is that too convoluted?
Well, it makes sense. I mean, the alternative that I was thinking is so Anthony, first of all, has an interesting question, which I think we should read. So he's asking, how come that the reverted T cells did not expand to fill the available space, which is a good point. I mean, there are other cases. There's one patient reported by Alan Fisher many years ago. Yeah, go ahead. Good. Would you want to answer that question?
So
what do you think?
Lymphopenia-induced proliferation is an important point, and it really does make things complicated when you're evaluating babies or older folks with low T cells. You'll end up with higher T cell counts than you might otherwise expect. And I think thematically, this is something our field has to tackle because we do have a reliance on counting things based on flow cytometry and how easy it is to get counts. Whereas the repertoire of lymphopenically expanded T cells ought to be quite narrow as compared with a count of T cells that might, through broad repertoire generation, otherwise reflect. So I think as a field, we should be moving towards coupling repertoire analysis with low T cell counts so that we really better understand how low is low. And the diversity then is actually more important when T cell counts are low than the low, because the low will fill to some degree with lymphopenic-induced proliferation. Now in his case, his T cell count of 300 or 600 or so was largely driven by lymphopenia-induced proliferation. And we know that later on he got some CAM path. His T cell count went to 0, and then it rose up by itself up into the 300 range. That's all probably due to lymphopenia-induced proliferation and probably a very narrow repertoire. We also had a clinical sense that his repertoire was narrow because he got norovirus when he was 15 or 16 or so and never shook it off. He had 7 straight years of diarrhea. And that gave us a hint that his ability to respond to neoantigens on the T cell side was really limited. But so I think he did try to expand his repertoire, expand the space a little bit, but T cells are not able to infinitely fill the space. And I think his count of 600 reflected the best that he could do. Okay, so there's a question about the marrow Anthony's asking, and we're going to get to that in a second.
Yeah, why don't
So I'm gonna.
Yeah, why don't we let Christin a few minutes here? Yeah.
Okay. So we did look at the bone marrow. We did a bone marrow biopsy, and it showed essentially no B cells or no NK cells. The marrow appeared to be hypocellular, and it had scattered granulomas. It had some hemophagocytic cells and mild erythroid atypia. So we did look at the B cells specifically. We sent them to, we sent a sample of this bone marrow biopsy to Stanford and had CyTOF performed. And so you can see the patient is sort of greenish teal color versus the red is a healthy patient. So he does have pre-B cells, but in the patient you can see that his pre-B cells sort of have a spike in concentration here, whereas in the healthy control, they sort of go through all of the stages of B cell development, and then as they reach immature and mature B cells, they sort of increase in concentration and then quickly leave the marrow. So the patient has some kind of mutation that's allowing B cell development, but they're unable to successfully differentiate past the pre-B cell stage.
And so I think we cut this slide for the sake of...
Yeah, I slightly disagree, though, with this interpretation. I don't think that a gamma chain mutation... Well, I don't think that it is a gamma chain mutation that prevents B-cell differentiation. We do know that patients, even with drastic gamma chain mutations, they create mature B-cells all the way through to immature and mature B-cells. And what they really lack is the capacity of the mature B-cells to generate plasmablasts and memory B cells. But other than that, I mean, they're perfectly fine. So in this specific case, when we saw him, Manish, here, we found actually, yes, that he did have the granulomas in the marrow. He had sky-high CXCL9 levels, which was speaking of a interferon gamma signature. So what I think is happening in this case, and we've seen the same thing, like I said, in 7 other patients with X-linked SCID, that lose their B cells over time, is that something is happening in the marrow environment that prevents complete maturation of the B cell differentiation at that point. So they have these early progenitor cells, but they don't go beyond that. And we've seen this with many cases. So I don't think it's a gamma chain mutation per se. All of these patients did have granulomas in their marrow. So I think there's something in the environment that at that point prevents B cell maturation.
I agree, and also the one even further twist curveball is what you and I talked about, which is the idea that sisters and mothers of these patients, they will have B cell genesis favoring the normal X allele, and that does suggest that there's some competition or favoring of the common gamma that works. Even though in the patients who lack utterly common gamma signaling, they can make B cells, as you pointed out. But in the ones who have some common gamma signaling, they'll still favor the ones that have the intact common gamma signaling. And maybe there's a degree there where there's some competition, and without competition, then you can make it through the checkpoint. But with competition, the ones who are an inch ahead end up being the winners. And I don't understand how that would be molecularly mediated, but it's worth throwing that twist in there.
Mm-hmm.
Go ahead, yeah.
So just to sort of kind of start to wrap up a little bit. So his medical summaries, we sent him to NIH for, as has been hinted at, for a lentiviral vector trial. And unfortunately, after he was released, as we've been talking about, it doesn't make a lot of cells. So he only had 1 million per kilo CD34 cells harvested. Was not a good candidate for gene therapy. So stem cell transplant was pursued, and he developed liver complications with chemotherapy and declined transplant at that time. So he presented back to UCLA for management of fluids malnutrition, and we sent him to Stanford for stem cell evaluation. And the thought at this point in time is that using Amgen 191 and fludarabine. So Amgen 191 is a humanized anti-CD117 monoclonal antibody, or c-Kit. And then fludarabine is a purine analog that inhibits DNA synthesis. By using a combination of these two drugs, that perhaps the regimen will be tolerable to the patient. Unfortunately, at this point in time, he's currently hospitalized for central line infection and a pneumonia. So, so further complicating things. He was initially discharged some late and sort of get control of his electrolyte abnormalities. But sort of in summary, we have several management issues with this patient at this point in time. So he and his family are still hesitant to pursue a transplant. And, the problems are his age, his infections, his history of norovirus that he's unable to clear, his poor nutritional status, liver cholestasis, electrolyte problems. And then the bone marrow itself has been substantially replaced by granulomatous tissue. So even if we give him some kind of regimen, is there space for new marrow? Even if we do a transplant, will it work because of how much of his bone marrow is occupied with granulomatous tissues, and how do you counsel him and his family, and where would you go from here? So let's see.
So I think we only have about maybe a minute or so before we should turn it over.
So remind me, this patient doesn't have any donor, any matched donor?
Correct.
No matched donor?
No, there's there's an unrelated donor in Europe. Yes. Mm-hmm. Sorry. No sibling donor.
Mm-hmm.
So why not? I mean, one thing you could consider, first of all, let's hope that the anti-C kit works. But in case it doesn't, another possibility that I would consider would be body to try to cool down whatever inflammation he has in the marrow, and then give an unmanipulated bone marrow transfer from the fully matched unrelated donor. And I would use minimal conditioning, actually, given the situation.
Yeah, I think that will have to be Plan B. The Amgen doesn't work. Mm-hmm.
Yeah,
and Andy pointed out that this mutation was identified in a Japanese cohort, and that's true. And we found that reference from the 90s and 2000.
Yeah, I didn't see any other data shown there, so I don't know. Any other questions from the? We should probably move on to the next case. I hate to stop this one. That was fantastic. So at this point, why don't I hand it over to my co-moderator, Nick Hartog, who will present or moderate the second case.
All right. So the next case, I'm Nick Hartog, as Andy said, and we've got another case of an infant over at the University of Michigan, presented by Tom, who's a pediatric heme-onc fellow there. So, Tom, you can go ahead.
All right, great. Thanks so much, everybody, for letting me present this interesting and we think important case. So I'll kind of jump right into it so we don't run out of time. Our patient, he first presented at 9 months of age to an outside hospital in April of this year with fevers, some respiratory symptoms, and vomiting. An X-ray in the ER showed diffuse reticular opacities. He ended up getting some breathing treatments, and Decadron and started on ceftriaxone, and admitted to the outside hospital. Initial labs there, he had some lymphopenia. Most prominently, his ALC was low at 300. Hemoglobin and platelets were okay, though, platelet elevated. And then CMP was notable for some elevations in his LFTs. And then soon after being admitted, though, unfortunately, he kind of had a rapid decline and was admitted to their PICU. And at that point, after he was started on BiPAP, developed a pneumomediastinum. He had chest tubes placed. Infectious disease-wise, he ended up growing out greater than 100,000 colonies of MSSA, and then his respiratory viral panel was positive for rhino and enterovirus. Interestingly, he continued to have lymphopenia with ALCs ranging from below 100 to about 800. He did develop neutropenia, necessitating 2 doses of Neupogen at the outside hospital. His Fungital was elevated as well. They did send off genetic testing, which I will get to a little later. later. But kind of given his persistently low ALC and his Fungitel being positive and his overall clinical respiratory picture, the outside hospital actually started treating him for presumed PJP pneumonia. And then he did have even further decline and was transferred over to our institution for initiation of ECMO. Delving into more of his past medical history, overall, it was actually quite unremarkable. Born at term with repeat C-section. Did have some delay for, some concern for developmental delay with babbling a little late at 7 months of age and crawling a little late at 9 months of age. He did pass his newborn screen and got his 2- and 4-month vaccinations without difficulty. Family history, his father and 3 paternal half-sisters have cleft palate, an uncle with G6PD, and then this maternal half-first cousin once removed, maternal grandmother's paternal half-sister's daughter, sorry, that's very confusing, ended up passing away at about 1.5 years of age following 2 transplants at Sloan Kettering. I'm leaving it a little vague there just to kind of leave some suspense.
And then, Tom, before, because I know the next slide you get into a little bit of labs, just wanted to pause and say if anybody had any questions or thoughts, kind of leaving it vague at this point before we get any farther.
That's good.
Doesn't look like anything yet, so yeah, go ahead to the next one.
Perfect. So soon after he arrived at U of M, he got placed on ECMO and CRT. Our service was consulted given this persistent lymphopenia and concern for immunodeficiency. And at that point, we initiated an extensive immunologic workup. Of note, G6PD testing was normal. Immunoglobulins, you can see, were low, IgG 290, IgA 48, IgM 73. And then peripheral flow T and B cell subsets noted significantly low T cells kind of across the board, CD3 of 104, and then also low naive and memory T cells as well, and then NK cells and then B cells significantly low as well. Antigen stimulation studies did show a decreased response to Candida and mitogen PHA, but a normal response to recall antigens with tetanus. Further mitogen stimulation showed a decreased response to the PHA and CANA and a normal response to PWM. And then we did send off T-cell receptor repertoire showing a skewed repertoire. And then TRECs at this time was below the level of detection on the assay. And then there was no signs of maternal engraftment on our studies, and then DiGeorge syndrome genetic testing was negative. So we can pause here, and any other thoughts on diagnosis or anything else?
So we got one comment.
Yeah, we do have someone, Carl, who is suggesting late onset ADA. Carl, do you want to say why you are thinking of a late onset ADA? You want to type it? Yeah, that's true. But yeah, but what features do you think are suggestive of normal newborn TREC? Yeah, it was considered normal. This patient had passed the TREC assay at birth.
Mm-hmm. And we'll go into the exact numbers, but it was normal.
Yes, T minus, B minus, NK minus. I mean, I would say the NK count actually initially was not that low, but yes, generally it is a T minus, B minus, NK minus. Yes, Victoria says the same. Can you go back a couple slides on the biochemical exams? There was one hint there also with the liver function tests.
Oh, liver function, yeah.
Yeah, that AST is clearly abnormal.
Mm-hmm.
And the other thing is, look what happens later in the next slide on the neutrophil. Right. Well, it's not just the ALC. ALC, of course, is very low. But, with ADA, you really want to look also at neutrophils. You want to look at liver function. So those are good hints. So there is a general suggestion here that this could be a delayed onset. I don't know how delayed. I mean, honestly, not very much delayed. This was still a young infant at this point.
just delayed enough.
Yes. It could be. I mean, sure, the infection may play a role. MST1 deficiency should be on the differential. True. All right, let's see what happens. Why don't you move on with the slides?
Sounds good.
What exactly did you do? How do you prove it?
So
yes.
Yeah, so I ruined it, I know. So the outside hospital, they were concerned about a primary immunodeficiency, so they actually had sent off the Invitae comprehensive SCID panel that did pop up with some pathogenic variants in ADA, a heterozygous deletion of exon 1, and then a missense mutation as well, too. Kind of given those findings, we sent off ADA studies to Dr. Hirschfeld's lab at Duke. As you can see, his ADA activity in his erythrocytes were low, but still technically within the normal range, but somewhat low. And then the adenosine nucleotide and deoxyadenosine nucleotide metabolite levels were elevated as well, too. And then kind of jumping back to our patient's newborn TREC screen. So his value was considered normal. You can see that, this is done obviously off of qPCR, so lower CT values equate to a higher TREC level. So you can see he was just close to meeting that what state of Michigan calls a borderline positive cutoff, which would have kind of triggered a repeat TREC screen for him. So he was close but didn't officially make it, and that's why he was called normal on his screen. Continued clinical course. So in our PICU, unfortunately, he continued to have some decrease in cardiac decline, developed some bilateral pleural effusions. He continued to be treated for his presumed PJP pneumonia and got regular IVIG infusions as well. And then his infectious history, he ended up growing staph hominis on blood culture, some pleural fluid, ended up growing coag-negative staph, and then he had a Klebsiella grow out from his respiratory culture as well, too. And then with the verification of an ADA SCID diagnosis, he was actually started on twice-weekly enzyme replacement in May of this year. We had started a workup for transplant for him.
So can you say exactly, when we say May 2018 for the ERT, where exactly are you in his clinical course at that point? Was he on ECMO already, or?
Yeah, he was still very sick at that time. He had been, he came to us in April, so he had been about a month into his course and had been quite sick at that time. So was still on ECMO, still on CRRT, still fighting these kind of various infections, was on broad spectrum antimicrobials. So they kind of reinitiated enzyme replacement therapy in the hopes that kind of getting some function back and kind of get him over the hurdle of these infections. And then, unfortunately, in June, he did develop some pulmonary hemorrhage and a large pulmonary hematoma, and his family actually elected to withdraw care, and he passed away at 12 months of age, unfortunately. It's kind of, we were trending his response to the enzyme replacement therapy. So in April, you can see kind of his initial flow results before starting treatment. And then he had started in early May his treatments. And you can see his NK cells and B cells were starting to come up, and we had actually sent off some repeat ADA studies to Dr. Hirschfeld's lab, which did show that the adenosine nucleotide levels and the deoxyadenosine nucleotide levels remained elevated 1 week after therapy, but had declined a little bit. So it seemed as though the therapy was starting to work a little bit, but then obviously continue to have a decline in his clinical status. Overall, just the adenosine deaminase deficiency, as many of you know, ADA is found within all cells, including red and white blood cells, and it's really due to a buildup of adenosine and deoxyadenosine, which are converted to the adenosine nucleotides and deoxyadenosine nucleotides, and that's what really inhibits DNA synthesis and cell replicative ability, and then you get increased apoptosis, causing the immunodeficiency.
Tom, we have one question out there. If we know the exact diagnosis of the cousin.
Yeah, so if you go through the records, there was, and genetics tried to grab some of the records too. The cousin was transplanted at Sloan Kettering, and the best of what we had known was that potentially they had caught a SCID, but in other notes we had read that it was bone marrow failure syndrome. So I think the initial kind of SCID potentially being a diagnosis is what prompted the outside hospital with his lymphopenia to kind of send off the in vitae comprehensive SCID panel. So there was a possibility that it was SCID in some of the notes we could hunt down.
Well, and in particular, the ADA SCID doesn't do very well with unconditioned transplant. If I understand correctly, what you said is that that cousin received unconditioned bone marrow transplant, right?
I'm not exactly sure. He got. They ended up getting transplanted twice, but I wasn't. I wasn't sure exactly what the conditioning regimen was at that time. It was in the early '90s at Sloan. Yeah.
Well, likely if he was an apple, likely.
Yeah. And so 20% of all cases of autosomal SCID are ADA, and then 15% of all SCID cases. And as you guys correctly guessed, it can present as delayed or even late. And so our theory is that this patient had the missense mutation, which can be associated with a little bit of residual enzyme activity, and then can lead to some a delayed onset. And then this patient, as somebody correctly noted too, did have a little bit of developmental delay as well. He did have the T negative.
So just to be fair, actually, there was TNIAID TNIAID actually had posted a comment. Could it be that the developmental delay was another evidence for ADA, for late onset ADA deficiency in this child? Yeah, maybe. Yeah. Although his clinical course was so complicated, it's very hard to judge on developmental delay in this case. But yes, yeah, possibly.
And then just an overview of treatment of ADA SCID, which I'm sure a lot of you are familiar with. Transplant is usually preferred if there's a matched family donor with over 80% survival. Patients can also receive enzyme therapy and then gene therapy on a clinical trial or in Europe where it's available. And then you would consider enzyme therapy kind of in our similar situation to ours, where we felt like this patient needed some improvement in his immunity to help fight infection, or if there's no good transplant options. And then what was really we felt like was one thing we wanted to touch upon, besides kind of the management here, was the newborn screening. And so this was a case that was missed on TREC screening. So tandem mass spec would have potentially picked up this. And so that has been used across the board for various metabolic disorders, PKU, et cetera, in newborn screening. And now we actually had a meeting for the state of Michigan a few months ago that we're rolling out this new mass spec assay, NeoBase-2, that will allow for additional screening of ADA SCID, and so hopefully we'll not have any more missed cases of this. Interestingly, it also would detect X-linked adrenal leukodystrophy as well too. So we kind of really wanted to talk about this case to show an interesting case and make people always kind of think of kind of delayed onset or late ADA SCID too, but potentially too, if any of you have any connections to the newborn screening in your state, to consider, having this added on with this new tandem mass spec, just so we hopefully don't have to see another case like this again. So that was one of the real motivations behind presenting this case as well, too.
So I would add, you're absolutely right. I think it's Great comment. I would like to add one more thing. That is the now in the newborn screening era, we give for granted that SCIDs is picked up by newborn screening, but as you pointed out, actually not all cases are picked up, and in particular these cases, which again I hesitate calling them delayed onset. They're hypomorphic ADA. They may skip. Actually, they may not be picked up by newborn screening. So whenever we have clinical cases that present early in life with, as severe of a phenotype as this actually was, and with T-cell lymphopenia, nonetheless, even if the patient had passed the newborn screening, we should still consider SCID as a possibility, and in particular, ADA deficiency and even PMP deficiency. And so, yeah, those are actually things that we should never forget. I mean, newborn screening doesn't solve all of the problems.
Exactly. So, we're hoping that this new kind of initiative we're taking in the state of Michigan will pick up any of these potentially missed cases.
What?
Yeah, it was good timing too, because actually the plan for the NeoBase 2 was already in the works, and then this case came along, so it gave us a little extra push. Because to our knowledge, this is the first case of miss that we've had in Michigan.
Yeah, and there are a few that have actually been missed. I mean, there are actually several cases that, in retrospect, people have shown that these were delayed onset ADA. They would have been missed by newborn screening if those patients had been tested at birth. I mean, they retrieved the Gut-Ricards and looked at what the levels of TRECs were in those Gut-Ricards, and they were not out of range. So this case is not unique in that sense. So there's definitely a need to do something else for ADA deficiency, and mass spec is a great technique, actually. Can you go back to one slide, the slide that you showed on the therapeutic algorithm?
Yeah.
I make one point. You said actually gene therapy is not available yet in the United States. So the situation is actually a bit more complicated. So first of all, this is actually a consensus statement that has been very recently published by a few of us who actually met and looked at the data and came up with this algorithm for treatment. And as you can see here, gene therapy is actually now put at the same level as a matched sibling donor or matched family donor transplant, just because the results of gene therapy with the lentiviral vector are in fact fantastic. And of course, there is no risk of GVH, which even with matched sibling donor and matched family donors is still there. So gene therapy is definitely something that for ADA deficiency is very, very cool and definitely could be life-saving. The problem with the gene therapy is that the lentiviral vector, there is a plan basically to commercialize it through a company, and until this happens, DONCON's protocol is not open for enrollment of any new patient. And so even if the treatment is there, no one can receive that treatment in the United States. There is one drug as a retroviral vector available in Europe, but patients from the US would have to pay for it. And the retroviral vector is not as good as the lentiviral vector for ADA deficiency. So, but the hope is that in a relatively short period of time, gene therapy will again be available. Now, what the insurance will do with gene therapy, because it's going to be it's clearly a great therapy for this disease.
And Gigi, there's a question right now asking you if this would have been caught if the TREC threshold was a little bit lower.
Yes, but this is all different. So the threshold for TRECs are basically are identified based on the general population. People don't mess around with values in the general population. Yes, you could use a more relaxed threshold for TRECs, but then what would happen in that case is that you would also recall several healthy infants, and so it's always difficult. I honestly think that the mass spec is the right solution for this problem, to be honest with you, rather than playing around with TRECs. The other possibility is to look at CRECs. A TRECs-CRECs combination might potentially have identified this case as well. because these patients are obviously B-cell lymphopenic too. But again, I mean, how effective is a TREC strategy in terms of cost benefits as opposed to TREC's mass spec? I still favor the TREC's mass spec, to be honest with you.
Are B cells known to be more sensitive to adenosine toxicity than T cells?
B cells actually are the ones that respond better and sooner to enzyme replacement therapy than the T cells.
I think that's what we actually had seen in our patient too. If I go back, yeah, his you can see B cells started to increase. After enzyme therapy.
Yes, that's what typically people see. But this is difficult to interpret because the time for the T cells to differentiate in the thymus is also longer. Mm-hmm. So this is 1 month, and what is it, 1 month of therapy basically. So it's difficult to say. One has to take this with a grain of salt. But B cells typically respond much sooner than T cells to the enzyme replacement therapy.
Well, thank you everybody for listening to we think this important case.
Thank you everybody for listening to we think this important case.
There was the ANC. One more time, the ANC.
Yeah, the ANC did improve as well too. I can drag up his lab. But yeah, it looks like his ANC had improved.
It's just the T cells take months, actually. One should not expect the T cell count to increase for the first 3 or 4 months after enzyme replacement therapy. It really takes a long time. Great case.
Okay. Well, with that, maybe we should wrap it up. I'd like to thank our terrific presenters today, as well as our senior mentors, Dr. Butte and Dr. Notarangelo, and thank you for attending. Again, if you have interesting cases to present for the webinar, please contact us because we're always looking for new ones. And I'll just thank everyone for attending. We'll see you next month.
Bye-bye.
Thank you.